Good morning, my trailblazers. Welcome to the DigiPath Digest, our weekly journal club where we discuss digital pathology and AI in medicine abstracts.
Learn about the newest digital pathology trends in science and industry, meet the most interesting people in the niche, and gain insights relevant to your own projects. Here is where pathology meets computer science. You are listening to the Digital Pathology Podcast with your host, Dr. Alexandra Zhurov.
Let's do the first abstract, and then I'm going to give you a few more updates because several of you are already waiting here. So let's not wait any longer. We have a pretty cool paper, and the first one is pretty cool. It's hallucination. It's about radiology, but it doesn't really matter because it's about hallucination filtering in radiology vision language models using discrete semantic entropy. A couple of concepts that we need to explain, but we have this vision language models. That's important. What is this discrete semantic entropy? They use this method to reject questions likely to generate hallucinations. And they were asking, can this improve the accuracy of black box vision language models in radiologic image-based visual question answering, VQA? So these are like concepts that people are using in this space. Let's start with discrete semantic entropy. They evaluated different data sets, de-identified data sets. There's a VQA Med 2019 benchmark. This is 500 images with clinical questions and short text answers, and diagnostic radiology data set. And here they had 60 computer tomography scans, 60 magnetic resonance images, 60 radiographs, and 26 angiograms. And I'm going to put the star here because I want to tell you something else after we review this one about the book that I'm writing, a different one. So, and they had ground truth corresponding diagnosis, and they evaluated GPT-0, GPT-1, and so this is the important thing. They answered each question 15 times, right? So they had these question data sets and images that they were asking questions about, and they let the model answer it 15 times using a temperature of 1.0. And the temperature is how much variability you allow the model to give you in the answers. If you reduce, and baseline accuracy was determined using low temperature answers 0-1. So low temperature is when they all cluster together and kind of are the same. So 15 times you would get the same answer. And temperature 1 when you allow variability. And then they grouped responses that had equivalent meaning. And then they recalculated accuracy, excluding questions with DSE over 0.6 or over 0.3. And what happened? So the discrete semantic entropy was like questions that had like this high entropy and the answers were excluded. And the results across 706 image question pairs, the baseline accuracy was 51.7 for GPT-0 and 54.8 for GPT-4.1. Not that great, right? Accuracy of a little bit over 50%. We would like more than that. But after filtering out high entropy questions, so over 0.3, accuracy on the remaining questions was 76.3 for GPT-0 and 63.8 for GPT-1. So basically, when you eliminated the questions that could give you all these different answers, you increased the accuracy, and the accuracy gains were observed across both data sets and largely remained statistically significant. So the conclusion that they are drawing is that discrete semantic entropy enables reliable hallucination detection in black box vision language models by quantifying semantic inconsistency. So can DSE identify hallucination-prone questions and improve the reliability of black box vision language models in radiologic image-based VQA, so visual question answers? This is like the question, but that's not really what they were looking for, because they did not evaluate the questions a priori. They evaluated the answers. So I had a little bit trouble understanding this and had to dive a little deeper. So what they did, they had a set of questions and they let the model answer. And then by how variable the answers were, they could say that, okay, the answers are too variable, so don't trust the model on this question. But they didn't really check how to reframe the question. They were not checking, okay, can we do better prompting? But they say that integrating the DSE as a black box uncertainty filter enables selective answering and explicit uncertainty display for radiology vision language tools, supporting safer diagnostic use, mitigating hallucinations, and improving clinicians' trust in AI-assisted image interpretation. That is the case. If we're going to see like 15 different answers, one says, pneumonia, the other one says lung carcinoma, non-small cell lung cancer, and the other says nothing, then you're going to not believe the answer to this question. But like, do you need to look at 15 different answers? That's a little bit overkill. But still, they figured out a method how to check if the model is hallucinating. And probably downstream, you can then have a specific prompt engineering strategy or question strategy or a set of questions that are built with this low entropy in mind. So I think this is amazing. Like, this work that people are doing is really cool. Another thing that I wanted to give you an update on, after each of these, I'm going to give you a little update, not to bombard you with updates. But so I was like diving a little deeper to understand these abstracts, and there is an option for you to dive deeper as well that does not replace reading the paper, but can help. These are AI-powered paper summaries that I started posting on the podcast. This is a members only thing, so this is a paid subscription. But if you're interested in listening to the summaries of all the papers that we're doing in the DigiPath Digest, they're all there from last week. I started doing this last week. I'm going to put all the ones that are available. Some are gated and not available, so it's not always going to be 100%. This is a super affordable subscription. You can check this out, and we're going to be doing this on YouTube as well. But this is AI generated, vetted by me, meaning I listen to all these summaries and I make sure that there's no nonsense. I listen to them also to basically go deeper into the papers. I do not always read the full paper. Sometimes I do. So that's something I created for you as well. And once I have it on YouTube, I'll let you know. And in the meantime, let's proceed to our next paper, which is something we probably all are thinking about because it is about the education, of future pathologists, education of future healthcare professionals in the world that is powered by AI in one way or another. So this is an article in French. So let's see if I'm going to have a summary of this one, but they are discussing impact of digital technology and artificial intelligence on the training of pathology residents. We are talking about benefits, limitations, and educational prospects, which is like anytime you go to a conference, anytime you meet a professional pathology or now probably any healthcare society, this is going to be a topic that people discuss. This is going to be a topic that people have opinions on. This is going to be a topic that students and those in training like have questions about and want to see specific resources. So what they say here is that young doctors who are highly exposed to digital technology in their daily lives, which is something I say or said several times, that the people that are now in training, they're digitally native for viewing images digitally native for, chatting with chatbots. They come with a lot of baseline knowledge on digital technologies, right? And digital pathology as such provides an interactive and collaborative training medium, facilitating learning and knowledge sharing. So this is we love digital pathology. We trained on digital pathology because Digital Pathology Association has ground rounds on digital images. There are YouTube videos that show histology, pathology on digital images. People know that, right? They already know how to navigate these images, but there is AI. The use of artificial intelligence during residency seems to raise more questions about the balance between benefits and risks in terms of skill acquisition. And that is the case also because this AI definition, AI landscape expands so fast. So when I was writing the book, the new super cool best thing were convolutional neural networks in image analysis for pathology. Now this is also part of the AI that we're using, but we now, as we've seen in the first abstracts, we have vision language models, we have foundation models, the transformers entered the scene. So it's expanding and a multimodality is entering the scene. So how do you learn about it? And I have courses, I have a concept. How this should be taught doesn't mean that this is the only way of acquiring this knowledge. That's something that worked for me. But what they say in this particular paper is that supervised use by senior staff, supported by theoretical teaching, is something that would enable future pathologists to master artificial intelligence tools without compromising the acquisition of morphological analysis and critical thinking skills. So that is a challenge because okay, I guess I would be senior staff as well if I was working at the university. I don't think of myself as senior staff, but I probably would be. So that would be somebody like me who already has some expertise guiding the people in a way that enables them to later guide themselves when new technologies are entering the scene, but also trying to figure out how they keep acquiring the morphological analysis skills that a pathologist needs and also critical thinking. And there have been publications showing us that use of AI will lead to de-skilling in certain areas. Then on the other hand, use of AI, when you have AI-aided diagnostics, is going to show you so many examples. So now you're acquiring this knowledge faster. So balance, kind of a philosophical discussion. If you have any opinions on that, what is missing, what should be there, put a comment in the chat, even if you're watching the replay, because this is an ongoing discussion and people are basically looking for input from everybody involved in this field, and that's going to be dynamic. There is going to be some curricula courses that will need to be updated probably every other year. But let's go to our next paper, which is region-based segmentation of lymph node metastasis in whole slide images of colorectal cancer. This is a pilot clinical study, and let me put a heart next to this publication because this is a no-brainer, low-hanging fruit use of digital pathology AI implementation that can basically improve any diagnostic workflow where you need to evaluate lymph node metastasis. And so you probably have heard about the chameleon challenges in 2016 and 17. There was this image in the computer vision medical space. They organized these competitions for different computer scientists, different companies to do something on medical images. And one of these competitions was the chameleon challenge, where the epithelial cells as chameleons are hiding in lymph nodes, and then you need to detect them because that defines, okay, is there a lymph node metastasis or not? And AI is very good in doing that. So let's see what happened in this particular study. I love this abstract because it's so straightforward. We did this. This study presents a two-stage computer vision model designed to detect colorectal cancer metastasis in whole slide images of lymph nodes. I love the study design. And the methods, it was a classification and segmentation pipeline optimized for both accuracy and efficiency. The model was trained on 108 whole slide images and evaluated on 554 whole slide images collected from 2 institutions. And we also had 2 scanners, Leica Perio AT2 and Hamamatsu NanoZoomer S360. So we have different institutions, we have different scanners. So we're trying to account for the domain shift. So basically variability stemming from different places, like an institution or like a scanner. So really nice. And the classification model achieved recall of 1 and a specificity of 0.935, super high, while the segmentation model reported dice coefficient of 0.818. This is also super high. And pathologists appreciated the model precision in distinguishing solitary cancer cells from histiocytes, reducing the need for peer consultation. So histiocytes, which are the tissue macrophages. They may often look similar to epithelial cells. And there's this question, okay, is this a metastasis? Is this an epithelial cell or not? And AI was pretty good in distinguishing this. And then the pathologists didn't need to consult that much. They still could, and they think it's a valuable second opinion, enhancing diagnostic confidence. So super straightforward use. And what they conclude is that AI can streamline workflows, improve diagnostic accuracy, and support personalized treatment planning. And this integration of AI into pathology workflows can redefine diagnostic standards while maintaining the critical role of pathologists. And we talked about it last week. If you have not seen the live stream or not listened to the podcast last week, we had a publication about what do patients think about the use of AI in medicine, in pathology in Europe. And they said, if a doctor looks at it and if it's validated, then it's fine. Like if it makes the diagnosis faster, better, more reliable, to a more personalized treatment, it's okay. Use AI, but have the pathologist, have the doctor in the loop. So that was a critical message that they gave in this other publication. And we want to keep it that way. I want to keep it that way. This is an interesting one. Automated non-invasive burn diagnostic system for healthcare using artificial intelligence. And I love the acronym AMBUSH. Where does this come from? AMBUSH AI, automated non-invasive burn diagnostic. I don't know. I like this one for a couple of reasons. So first of all, this is a combination of modalities. That's one of the things that I like. So they wanted to develop technology to predict burn wound depth using a combination of an FDA-approved ultrasound modalities and interpretation of these images using artificial intelligence. So we have imaging, we have ultrasound with FDA-cleared devices, approved modalities. And then we have AI using these images, but not only these images. So how does this usually work? So physical examination by burn surgeon is a diagnostic gold standard to determine the need for burn surgery. And the problem that they have is distinguishing between deep, partial, and third-degree burns to determine the need for surgery. So this is like their problem and the ultimate diagnostic challenge. And the accuracy for this process is 76% for burn experts and 50% for non-experts. So I don't know how many burn experts we have in this field, but usually you have less experts than non-experts in any discipline. So if non-experts are looking at it at 50%, it's 50% accuracy. So let's see if AI can do better. Spoiler alert, it can. But another thing that I like about this paper is they worked with a pig burn model first. And I'm a veterinary pathologist, and veterinary pathologists are very much translational scientists. So I see this translational aspect of research here. They had a pig burn model. They had 12 pigs. This was used to develop the initial AI framework. So here we have like how veterinary pathology, veterinary medicine supports something that later can be used in patient treatment. And I got this question, and I was recently interviewed for The Pathologist. This is a publication that supports pathology and pathology laboratories. I was speaking at a conference in London, Digital Pathology and AI Conference by Global Engage, and they asked me this question, like, how can veterinary pathology support anything that later happens with patients? And there are like multiple aspects of that, but this translational aspect is one of these things. So you had an animal model of a human disease, you developed an initial framework, and then it was subsequently tested in non-randomized prospective study of thermal burn human subjects. And there were 30 subjects in the study. And they used images from tissue Doppler elastography imaging, TDI, to measure tissue stiffness, and then harmonic B mode ultrasound to identify anatomic landmarks. And also digital photographs were collected. And not only this, biopsies were obtained from 5 subjects. So not all of them. These subjects who went to OR for debridement, and this was ground truth for AI image interpretation. So when you look at the numbers here, they're not that high, but then the results show that the AI algorithm identified third-degree burns in pigs with 100% accuracy. Obviously, we only have 12 pigs, so, if we had bigger number, maybe we would not have 100% accuracy, but it's still pretty high. Well, the highest, it cannot go higher than that. And then the AI method achieved a 95% accuracy in identifying third-degree burns in humans. So conclusion, these results indicate that the strategy to use AI interpretation of B-mode ultrasound and TDI images to increase diagnostic accuracy in predicting burn depth is feasible. And how cool would it be to give this tool to the non-experts that are trying to do their best job to increase their accuracy and also have a human in the loop, like we are always saying that this is what we want, right? We have here like something that introduces doubts. Benchmarking large language models-based agent systems for clinical decision tasks. So, not all is roses with AI, my friends and trailblazers, and you probably already know that there is no black and white. There is a technology that we're trying to figure out how it can benefit patients from, basic science through translational to the clinic. And in this last paper for today, there was a benchmarking exercise undertaken, large language model-based agent systems for clinical decision tasks. And agentic AI, I think it's still like the new kid on the block. What are these agents? Agents, in short, are AI programs that can coordinate other AI programs. So agentic artificial intelligence systems, they are designed to autonomously reason, plan, and invoke tools have shown promise in healthcare. So like agent is going to be something that can maybe like retrieve your emails, like in the consumer AI, retrieve your emails and then like prioritize them for you. So in healthcare, maybe that's going to be something that's going to prioritize cases for you. But of course, we need to do systematic benchmark, and it's limited for real-world applications. So they evaluated these two such systems. Open source OpenManus built on MetaLlama 4 and this one was the open source extended with medically customized agents, and Manus. So we have the OpenManus and Manus, a proprietary agent system employing a multi-step planner, executor, verifier architecture. And I hear this planner, I think there are agents that can like plan your trips or book your Airbnb and like all these things. So there was some medicine specific planner, executor, verifier architecture, which is like an official architecture in this space. And both systems were assessed across 3 benchmark families: Agent Clinic, a stepwise dialogue-based diagnostic simulation; Med Agent Bench, a knowledge-intensive medical Q&A dataset; and then, I like the name, Humanity's Last Exam. Humanity's Last Exam, HLE, Humanity's Last Exam, a suite of challenging text-only and multimodal questions. And despite access to advanced tools like web browsing, code development and execution, and text file editing, agent systems yielded only modest accuracy gains over baseline LLMs, large language models, reaching 60.3% and 28% in Agent Clinic MedQA and this MIMIC. The other one, which one was that? Here, Med Agent Benchmark, and 30% on Med Agent Benchmark, and 8.6% on the Humanity's Last Exam. So I guess AI is not going to be taking our last exam, but like how low is that? Very low. So multimodal accuracy remained low, like below 30%, 15.5 on multimodal Humanity's Last Exam, 29.2 on Agent Clinic, and the resource demands increased substantially with over 10 times token usage and 2 times latency. And 89.9% of hallucinations were filtered by in-agent safeguards. I want to highlight that one, and I'm going to tell you a story about this one. Hallucinations remain prevalent, and these findings reveal that current agentic designs offer modest performance benefits at significant computational and workflow costs. So here's a lesson for Dr. Alex, meaning yours truly, that it's so I always get super excited about these new technologies. And when I learned about agentic AI, I'm like, oh my goodness, now you don't have to do all this like mundane things of opening windows, looking through databases, all this stuff. Like, let's just replace everything with agents. But in this decade in digital pathology, I already learned that I need to keep my own enthusiasm in check, because this already started when deep learning entered the scene. And I thought, oh, like the classical computer vision is you can throw it into the garbage. Please don't. So I already know myself. The safeguards, I wanted to tell you about the safeguards. There's a story about that. So these safeguards were built into this agentic system. So this was something that was mentioned at the NCCN AI in Cancer Care Summit last year, that these tools need to have safeguards. And these are basically like guardrails, rules that whatever the answer of this model or whatever the behavior of the model is, if it's outside of these guardrails, it's filtered out. It's not going to be used as an answer to anything, or it's not going to be used for decisions. So that's like, there has to be a built-in feature of the AI tools that we're using for medicine. For example, when I use these tools for content creation or anything I'm writing, paper writing, where you always now have to disclose that you used AI, and I use a lot of it. But basically you can start with, hey, this is what I'm writing, this is what you are allowed to do, this is what you're not allowed to do, you're not allowed to invent, you're not allowed to go outside those of verified web sources, you always need to cite, and things like that. So you can build this into your AI use as well. But yeah, agents are not there yet. Let's start working on better agents. So the technology, the capabilities are there, but there is a little bit of a gap between the technology and the practice. Let me see if I have any more updates for you. Oh, yes. I wanted to tell you about a conversation I had recently with Michelle Mitchell, a patient advocate. She was also speaking at PathVisions last year. PathVisions is the annual conference of the Digital Pathology Association, and last year's was very much focused on patients. And I'm writing this book. It's available for pre-sale, and I want to share a post with you. I'm like softly starting to announce it. It's not like yet in full blow, but let me share a post I posted on LinkedIn. Okay, here. You got the report, but did anyone show you the images? So she was a breast cancer patient and then was involved in cancer care and patient care of different patients. And she knew a lot about the treatment. She went through treatment. She already 11 years or 12 years. And I'm going to invite her to the podcast after her diagnosis, after being done with the treatment. She saw her pathology images. She saw the slides, even though she already had the knowledge, had the report, explained the report to herself. She says that looking at the images and realizing what was happening in her tissue was the very powerful stimulus to basically change her life. She lost weight. She started taking care of her health in a totally different way, even though it was already 11 or 12, over a decade after she was diagnosed, after treatment. Seeing these images gave her a different level of understanding. So this is what this book is going to be about. It's going to be about how to get access to your images and how to talk to your pathologist, how to develop a relationship and this conversation about what's happening in your body with your pathologist, with the images. And something else that I wanted to show you, because we have a discussion on LinkedIn about it. And obviously one of the points is oh, well, this is a specialized imaging. You're not patients may not understand it, giving them the report, which is already the case. You are entitled, and it's a mandate to give your pathology report in the patient portal, even before often you talk to your clinician. There's always this hesitancy. These are specialized images, like when you break a wrist, which I had the honor of breaking some time ago. You look at the x-ray and you see the break. It's intuitive. But pathology image is not intuitive. Well, nor is magnetic resonance image or any of these ultrasound images that are not so intuitive. And yet we get our radiology images or access to these images. So we have the right to also see our pathology images, and this is what this book is going to be about. So if you're interested, follow on social media and check what the development. Obviously, before you escape, we are focusing on this book. Digital Pathology one-on-one. All you need to know to start and continue your digital pathology journey. The PDF of this book is free, and at USCAP there is going to be an option to get. There's going to be a limited number of copies that you can basically get. There's going to be a book giveaway. If you already have the book, I'm going to be there. I'm going to be signing the books. And if you are planning on going to USCAP, just send me a message wherever. Leave me a comment under this live stream. Send me a message on LinkedIn, mostly on LinkedIn, or send me an email if you're on my email list. And I would love to see you there. I would love to say hi in person. I hope to see many of you there. And I talk to you in the next episode.